interesting. I think cyst discussion is very important. And now I have, in my opinion, the most difficult topic because the Sylvian cyst is the most controversial. But for indication, I think less than 10% of the so-called radiologically called arachnoid cysts we treat surgically in my department. So it's not that frequent. Okay, I have a consultant contract with Storz Company. So, as we have heard already, because somebody there in the third row was asking, why do you treat these cysts? It's controversial. They have frequently non-specific clinical symptoms. And well, we see some of them, we see some slit valve mechanism, and I will show you the images of the ventriculography and cystolography we do in my department, the radiologists do. So the origin is quite unknown, although we have this slit valve mechanism, I think, in probably all of them. Majority is in the middle fossa, so we have quite a number of Sylvian cysts. It's only 1/3 in our series we treated, but it's the most frequent indication for referrer. All the other locations are less frequent. So the question is the symptoms, are those related to the lesion? Well, headache, seizures. Progression in size is quite difficult when you see such a lesion here. I think most of them are symptomatic if they come up with a diagnostic radiological workup for a headache or something. Is there compression of adjacent structures? Is there vivid CSF circulation in the cyst? Of course, then it's not going to be symptomatic. So this is what we do. We do, particularly in the Sylvian cyst, not in the supercellular. I think it's not required. In most of the interventricular is not required, but in the Sylvian cyst, all of them get a cystosonography in our department. So this is an example here with a CAT scan, and you see this is then done frequently after injection of contrast dye, and you see that the cyst, if it at all enhances, will enhance very, very slowly. After 3 hours, frequently we don't see any contrast dye in the cyst. You can do this also with the MRI, so particularly in the children we do MRI. Actually MRI cystosonography is, at least in Germany, is off-label use. So actually this is not allowed, but it's of course better because you don't have the X-ray. The cystosonography for the CAT scan is just a standard myelography, so there's no problem with the cystosonography in CT. Also, CT has an advantage; you can really compare the data. I'm not a radiologist, but MRI is not it's individually the analysis is very individual, so you cannot really compare the inflow and the flow of the contrast dye from one case to another. So CAT scan would be better for at least a follow-up to analyze. So this is what it looks like again. You see here that everything is filled in the subarachnoid space, ventricles are filled, but the cyst, there is no contrast dye in it. And this is then even later, this is really usually 30 and up to 60 minutes, and 3 hours later, you see there's some contrast dye coming in, but it's very slowly. So this is an isolated compartment, at least that's what we can say. And it's space occupying, right? We have a midline shift. So this would be a finding we would treat if patient has any symptoms. If he has no symptoms, well, you usually don't do this, right? This is an invasive work. So when we think now about Sylvian cysts, we can treat them microsurgically. I think probably most of them are treated microsurgically. Who does this Sylvian cyst endoscopically? Here?
Depends.
Who does it microsurgically?
Depends.
Okay, so who does intraventricular cyst microsurgically? Yeah. Supercellular. You see, Sylvian cyst is the most difficult. So it's really difficult because, well, there's some advantages you can use. Think about endoscopy. It's a small burr hole Well, of course, you don't have much trauma for the approach, and well, you can get additional information at the target. Yes, you can. Even if you just do a small opening, you can get through with the endoscope and look. The surgery we do with the Sylvian cyst is all we have done cystocystonostomy. I think it's very helpful to do this with a navigation, because you really want to calculate a straight approach from the burr hole to the cystocystonostomy spot. I think this is very important, particularly if you have a smaller cyst. It's not that easy. And usually, if they ask your resident to mark the skin incision, it's always wrong. It's never the right spot. So I think this is very helpful. Navigation, intraoperative navigation, sometimes you need. Sometimes it's a very thick layer and you really cannot identify any structures. It might be helpful to really find the optic nerve and the carotid. So this is the intraoperative view. Typical, a nice cyst. You see here, we look, it's a right-sided approach. We here see the carotid, the optic nerve, and the oculomotor nerve. And then you have basically two possibilities you can do here in between the optical carotid window. I think here it's easier because all the vessel-receptive ophthalmic artery, which is far anterior, all the vessels go to the right or posterior. So I think this is the most safest area, but it's also very close. It's very small. So frequently we actually have to do at least a second opening or just an opening at the lateral carotid close to the oculomotor nerve. And this is then how this is done. In this example here, you see it's done at the lateral to the carotid artery, and then you perforate. It's like a standard stoma. You always have some if it's a large opening, you have to have some manipulation, or frequently some manipulation at the oculomotor nerve. And then I think what is important is to check whether you really did the opening to the prepontine system. We frequently have an opening, and if the layer is very thick, we have an opening to the sellar area and not to the prepontine system. If you check this, you will find this during the procedure. You just enlarge your opening, and then you can have a nice cystonostomy. And this is a typical post-op MRI. We don't do in all of them. We don't do cystosonography post-op. But here, this is very clear that this is a nice communication, because you have all this flow sign in the cyst. I don't have this at all in the pre-op MRI. Never. Okay, it's another example here. How to open and remove this. If you have a wider opening, particularly if you have a very thick membrane, you try to remove a lot of this membrane. This is, of course, more time consuming and more difficult to remove this, but I think the larger the opening is, the less likely it is to have a recurrence. Another example, I think I don't want to go too much into detail. I just show this to you because here we have a post-op cystosonography, and you see this, that this is an immediate CSF flow in the cyst, and you see that there's immediate contrast enhancement in the cyst. So it's a very different image. This is like, now you don't have a compartment anymore. Now this is the same like a subarachnoid space. There are some cysts, the paraxial cysts we have to do, from the cyst we connect those to the ventricle. I think in those the navigation is intraoperatively much more important. Here usually you find your spot, but for positioning of the skin incision and the burr hole is very important. You see that everything is just a pretty typical picture. So this is the archnoid layer appears to be much thicker than in the standard archnoid surface. This is a very nice case because you can actually, it's a translucent membrane, so it's easy to go through. because there's no risk that there's something behind. Unfortunately, it's not always like this. Another problem you see here, that there's a lot of membranes, so this is a case where we would try to remove a lot of these membranes to create a wide opening.
These are bipolar?
That's bipolar, yeah. We actually have no monopolar for the water system we have. Well, there's available, but we don't have it. So it's basically the same stuff we do with the ventriculostomy. So just perforation, enlargement of the deck forceps, and then, well, you can remove step by step some more of this, and then create a large opening. This is another position you see here now. This is between the optic and the carotid. Just need some time and some courage. Usually you can remove this membrane from the carotid and from the nerve without any injury.
Would you recommend it?
Do it endoscopically?
To remove some...
It depends. This is, in such a case, you see that there was a lot of membranes. I think this is a case which has a high risk of recurrence. I come to this. We have 5 recurrences in our series. So you see that this is a very thick membrane. I would try to create an opening as big as possible. But of course, you really have to be very confident that this is the Archnoid you take and the vessels are intact and you don't pull the vessels.
Sure.
Let's just see if this is a case where we look at the pituitary. I don't think so, but I'm not that sure. So if we have this would be interesting. So sometimes if you don't find really the exact spot, particularly if you don't see exactly where the carotid is and where the optic is and the oculomotor nerve, then sometimes you really open to the intracellular space and then there's no connection to the prepontine system. We tried to, in the beginning we did very small openings, and I think, well now we try to do, at least if we have small openings, you do a couple. Oh, it's not in there, the cellular system. Okay, so this is the series. It's a little more than 20 years collection. It's collection from 4 different places where I worked. I have only included cases I was, during the time I was involved in, no, I didn't do all the cases, no. But so this is cases from Gab and Schröder, from Greifswald, Gab and Hannover, and then Wolfgang Wagner and in Hamburg with my team. So it's close to 100 procedures now, it's 86 patients. It's not all Serbian. I come to the Serbian stuff later. And mean age is 30 years, so most of them are adults. There are a couple of cases children, but most of them are adults. All were treated endoscopically. And then I don't want to point all this out, just look at the temporal Serbian cyst. So it's about 1/3, 33 cases, a little bit more, maybe close to 40%. There was clinical benefit in 80% of those. You think this is good, but when you compare this with the other cysts, it's actually not very good. Okay, 80%, where we have a couple of locations where actually we have 100% success rate endoscopically. So it's 80%. Radiological benefit, 60%. This is probably true because frequently you don't have, the good shrinkage in size in these. What is important is we have 5 recurrences. Follow-up, mean follow-up is a little bit more than 2 years. We have 1 recurrence after 5 years. We have also 1 case who had actually 2 recurrences, very early. We have evidence that this was open before, cystoscopy was open, then he had a recurrence 6 months and I think 9 months after surgery. And this was the one who received the shunt, the only one. But he received the shunt after the second recurrence, then we thought, well, this doesn't make sense. So since the shunt, he's fine. There are a couple of transient complications. And these transient mainly it's oculomotor nerve palsy, not real palsy, just a slightly dilated pupil. If you manipulate at the oculomotor nerve, you see that it's intact, it will resolve within the hospital stay. But we counted this. This is the most frequent transient complication. We have some abandons, so pure endoscopy abandoned in 6 cases. All of them were for bleeding. Bleeding is a problem. If you have some bleeding, particularly when you do the incision of the dura, and you're just bad luck, there's some blood there, then